Hi everyone, a very good morning to all of you. Myself Dr. GSN Koteswara Ra, Associate Professor at KL College of Pharmacy, KL deemed to be University, Guntur. First of all, happy Teachers Day to all my dear fellow teachers. So as we know, teaching is a noble profession. Today we have with us a renowned teacher as well as industrialist, Dr. Kumar V.S. Nemmani, Director, Shri Vishnu College of Pharmacy, Bhimavaram. I know him personally for a couple of years and I heard a lot about him. He's a good orator, and today, along with you all participants, I am also eagerly waiting to listen to his lecture because he is an expert in drug discovery, particularly in neurology area. Along with that, I also heard that he used to take classes even today regularly. So out of that passion and interest, I am waiting along with you all to listen to him. Before going into the session, let me take a minute in order to present a small video about KL University. Okay, welcome back. Now I request our organizing committee members for today's national webinar on holistic approaches to optimize treatment outcomes in severe asthma patients, 9 P's of severe asthma. So now I request our today's national webinar chairman, Dr. G. Chakravarthi Garu, who is a principal of KL College of Pharmacy. Hello, sir. Good morning.
Good morning.
I request Mr. B. Nagaraju, convener of today's national webinar, to please be on the screen. Hi, Nagaraju.
Hi, sir. Good morning.
I also request Mr. A. Narayana Rao, who is acting as organizing secretary for today's national webinar. Hello, sir.
Good morning, sir.
Yeah. So now I take the privilege to request our principal, Dr. G. Chakravarthi, sir, to please give the welcome address.
Good morning, everybody. Good morning, one and all. I welcome all the pharma delegates, pharma community delegates to the national webinar on holistic approaches to optimize treatment outcomes in asthma patients. So what I would like to bring you notice at this juncture is we would like to focus on exactly in the current pandemic situation. What we feel is this is the right time, right seminar to know about the respiratory problems when we come across when patients particularly suffering in asthma. So at this juncture, we thought we go with this type of seminars. It is going to be useful for the public. We can reach out the public and we can serve to the community, pharma community. That is the reason I just asked Nagaraju sir, why don't you conduct one webinar in the pharmacology area? Then immediately in a couple of days, he come out with this idea, and that's how it materialized. I really appreciate all the organizers and KL College of Pharmacy association with Mybo Group, the active Mybo personals. And the objective of this seminar is to bring awareness to the students and pharma community about the treatment outcomes in severe asthma patients. So I thank one and all for registering for this seminar, and definitely you are going to get something out of it. And thank one and all the organizers taking a technological advances and doing the seminars this way. And really appreciate Mybo Group also. Series of webinars they are conducting, and the way they are conducting these seminars in a holistic way. I thank all the members organizing this one. And once again, I thank all the pharma community delegates to the national webinar on holistic approaches to optimize treatment outcomes in severe asthma patients. Thank you for giving this opportunity. Thank you one and all.
Thank you very much, sir, for your warm welcome address. Now I take the privilege in requesting today's event convener, Mr. B. Nagaraju, to please address the gathering.
Myself, Nagaraju Bandaru, working as assistant professor in KL College of Pharmacy. First of all, happy Teachers' Day to all my fellow teachers. Good morning to all the dignitaries, faculties, and student participants. I take the privilege to invite you all for today's national webinar on holistic approaches to optimize treatment outcomes in severe asthma patients. 9 P's of severe asthma by esteemed speaker Dr. Kumar V.S. Nemmani, sir, who is having a vast experience in industrial research as well as academic research. That sort of joint research experience is very rare, and I hope today we all are going to listen an interesting talk by our Kumar Nemmani, sir. Earlier to KL University, I worked at Shri Vishnu College of Pharmacy, and I have good experience with our today's speaker. He is very friendly and always encourages the talented people. Under his guidance, the college is progressing very well, and the research outcomes are also appreciable. I hope he will give an insight on the selected theme in his presentation, and we can gain useful knowledge, which can we make use of in upcoming future. I thank to Dr. G. Chakravarthi, sir, Principal, KL College of Pharmacy, for encourage to conduct this webinar, and I also thank to Dr. GSN Koteswara, sir, for his support and suggestions. I learned so many things from you, sir. Thank you. With these few remarks, I congratulate all the registered participants for their interest, and without any further delay, I request our Koteswara, sir, to take the program forward. Thank you.
Thank you very much, Mr. Nagaraju. Now I request Dr. Rajshekar Reddy Alwala to introduce our today's speaker, Dr. Kumar V.S. Nemmani, sir.
Good morning, sir. Thank you. And good morning, dear participants. Myself, Dr. Rajshekar Reddy, working as an assistant professor in the College of Pharmacy, KL-MYBO University, Guntur. And happy Teachers' Day to all the teachers who are striving for shaping the careers of young generation students to achieve their goals. On this auspicious day, it is my privilege to introduce today's esteemed speaker, Dr. Kumar V.S. Nemmani, sir, from Shri Vishnu College of Pharmacy, Bhimavaram, Andhra Pradesh. Dr. Kumar sir is currently working as a director in Shri Vishnu College of Pharmacy from 2018 onwards. Sir has obtained his B Pharma and M Pharma in pharmacology from Andhra University, Visakhapatnam. He has completed PhD degree under the guidance of ex-professor and director P. Ramarao sir, Naipur Mohali. Subsequently, he was associated with Professor Jeffrey S. McGill University, Montreal, Canada, for his postdoctoral fellowship for 3 years. Dr. Kumar sir has over 14 years of drug discovery and development research expertise and managerial experiences at various positions in industry. He has associated with leading research centers in India, like Dr. Reddy's Research Foundation, Hyderabad, Pyramid Life Sciences Limited, which is formerly known as Nicholas Pyramid Research Center, Mumbai, and Lupin Private Limited, Pune. He is an expert of advancing novel discovery programs right from the target selection to candidate nomination. Some of the nominated compounds by him are in the advanced stages of clinical development. SAR has established various animal models for screening large number of synthetic compounds and natural products and executed mechanistic and value addition studies. SAR successfully submitted and defended investigational new drug applications which led to clinical development of few molecules. During his academic and industrial research period, SAR has published over 40 international publications and guided several postgraduate students. He actively participated and presented research works in various international and national conferences, namely Society for Neuroscience, International Association for Study of Pain, American Pain Society, Canadian Pain Society, American College of Rheumatology, European League Against Rheumatism, Gordon Conference, American Association for Cancer Research, European Association for the Study of Diabetes, and Indian Pharmacological Society, etc. His area of research interests include discovery and development of novel agents against chronic pain, neurological disorders, inflammatory and autoimmune diseases, metabolic disorders, and cancer. With this brief profile, I would like to welcome Dr. Kumar V.S. Nemmani, sir, to take over the session. Thank you so much.
Thank you very much, Dr. Rajshekhar, for giving such a wonderful presentation about today's speaker. Hello, sir. Dr. Kumar, sir. Welcome to the today's national webinar.
Yeah, sir. Good morning. So my voice is clear?
Yes, sir. Everything is perfect, sir.
So should we go for the presentation?
Yeah, now the session is over to you. So at this moment, I would like to thank you for accepting our request immediately, and within a short span, you coordinated with us very well, I can say. So at this open platform, I would like to thank you very much. Even out of your college administrative works and other academic works, you find time to give your talk on a wonderful topic, a selected topic, I can say, because you promised me that you will be giving an excellent topic, especially for this webinar. So thank you very much, sir, for such a topic. Now the session is over to you.
Yeah. So first of all, happy Teachers Day to all the fellow teachers participating in this webinar. And let me thank Mr. Nagaraju for inviting me to give this webinar. And I readily accepted this because I have given a commitment to Ishwar long back that I give a webinar. And I also like to thank the principal sir, Chakravarthi sir, for accepting this proposal and for giving me this opportunity to talk one of my research interests. As Rajshekhar introduced, I am a jack of all trades, master of none. I must admit that. And with the limited knowledge and the limited exposure that I have, I try to justify today's topic. I hope it will be interesting and it will be useful for academic programs as well as those who are interested in the research. So with this note, let me start today's topic. So my PPT is usual, Ishwar. Should we go ahead?
Yes, sir. We can proceed, sir.
Ishwar, is it ready? Should we go ahead?
Yes, sir. Yes, sir. It's visible, sir. Everything is fine, sir. Audio, video, everything is perfect. You can proceed, sir.
Yeah, excellent. So today, as you see, the topic that I choose is holistic approaches to optimize treatment outcomes in severe asthma patients, 9 P's of severe asthma. Many of you may be wondering what are these 9 P's, and I want you all of you to think few minutes and think what are the all possibilities. So in fact, this topic you can change just 2 words, and it can be a series of talks on this similar title. Just remove the asthma. You can put maybe arthritis, or maybe you can keep COPD, or you can keep diabetes, or any other disease, in fact. And that's the guidelines, guiding principles, which I'd like to present today. And so that the most of the participant will appreciate the beauty of science in various diseases. And you may be wondering that holistic approach should be one, but why holistic approaches here? And the point that I want to impress upon to each one of you is each patient is unique and each patient profile is unique, and we need to come up with an approach which is individualized and which is holistic in nature. So though it is an holistic approach, and there are approaches when dealing with the patients. And the same patient also, the approach that you take today may not be the same approach that you do maybe after 3 months, maybe after 6 months. So this topic is big, as you see, it's a holistic approach. So what I'm trying to do in this seminar is that it's more like a Google satellite view of the globe. So where you see all the peripheral parts of the world, and you see definitely the bigger ones, bigger countries in a much better fashion. And in some cases, as Google does, you focus, and we did look at the microscopic view. So we'll go inside the cell, we'll come out of the cell, we'll look at cells as together as tissue, we'll look at tissues together as an organ, and the tissues, we'll look at together all the organs together as a human body. So that's how it is looked at it, and that's how we should looking into analyzing that data. So today's the webinar participant, when I analyze it, and the number of registrants are more than 2,000, and out of that about 40% are the BPharm students, about 20% are faculty, and 20% is family students, and a few number of research scholars are there. So it's a heterogeneous group. So I want to give this topic in such a way that every person in this webinar will enjoy the talk. So I try to balance out this story, which is interesting to everyone in this webinar. So with this note, let me start the science part of it. So I didn't yet define you what are 9 P's. I hope all of you must be guessing it, and see when I come to the slide what your guesses are right or not. And these are guiding principles when addressing any disease from a scientist point of view, or even from an academician point of view. And these guidelines will exist forever. I hope every one of you are guessing it, and let's see who all or how many of the PPs do guess it correctly. So before going too much into the science, I must admit that the parents give life and the teachers give direction to the life. In my case, these are my gurus who have given direction to my career and to my professional career. That you see in the first top left side, Professor S. Narayana. Many of the students from Andhra know about sir for sure. And if sir, I might have been not there in that college when I was a student, I might have not become a pharmacologist for sure. By looking at sir and by looking at his teachings, I got motivated, and I selected this research, and I selected the specialization in pharmacology. Today, if I say anything good in today's talk, if you feel it is something good in the talk, and that should be due to my professor, my research guide, that Professor P. Rao sir. So his teachings has a lot of philosophy in it, more than science, which he has taught us for 5 years, and he has been an instrument for generating a series of students from the Mybo. So I learned and generated interest from pharmacology because of Professor P. Rao sir. So next to him, Dr. P. Ramesh is such a wonderful, organized person. And there's something I look forward for him and try to mimic to be organized. And next to is from my PhD, my postdoc guide, Professor Jeffrey S. Mogil. And he's so simple and he does so complex things. So I came to know how to do complex things in a simple way. So that's what the learnings that I got from my teacher. These are the 4 leading persons in pharma field. And Professor Jeffrey S. Mogul is a leading research scientist in pain research. In some other day, the learnings that I had in pain research, I will be giving a seminar. And you will know what I learned at McGill at that time. So bottom you see Dr. Ram Vishwakarma is the director, ex-director. And he has taught me how to be a scientist. This is very, very, without telling anything. So I try to mimic how to be a scientist at every moment. And sir has shown that while we are associated in industry. And it's very unique style and content. So next is Dr. Rao is so passionate And even today, every day he works more than 16 hours, and he doesn't sleep many days when there is some question is there in his mind. So passionate. I learned how to be passionate about doing things from sir. And these are all living legends, and I'm continuously in touch. And next to my my super boss, ex-CSO Pyramid Limited, Dr. Soumya Sharma, and I learned from him how to do science and how to manage science, how to deal with scientists. These are very unique qualities in each one of them, and all these qualities I try to mimic. So what I am today is more of a mimicking those personalities, those virtues that I try to copy and mimic and deliver every day today. So on this day, being Teachers' Day, I call these people as my gurus. I dedicate this talk to each one of my gurus. So without guru, you are nothing. And after some time, you also become a guru. Right now, I am a guru for some. Hopefully, I'll also do something which my gurus have done to me with them also. So with this now, you see what these are. So if you want to achieve any optimal outcome, what is optimal is maximum outcome, my best possible outcome. For any disease, in fact, these 9 P's are common. You need to understand physiology, you need to understand pathophysiology, you need to understand pathology. These 3 words are so unique in case of asthma. And if you understand this physiology, pathophysiology, and pathology of the disease, you can characterize the subject and characterize the subject having a specific phenotype or the endotype. So these are 2 typical terms that are used. Phenotype is more of a characteristic of the subject because of the interaction of the subject with the environment. And endotype is one molecular mechanism or molecular changes that happens inside the body that is leading to a phenotype, which you see at later slides at molecular level. I hope I go a little bit deep into some molecular aspects, but it's still, it is, whatever the extent I go, it is injustice to the topic because we are trying to cover the holistic story today. Hope with these limitations, you understand what we are trying to do. So once you understand the disease, the approach is to go for the addressing that particular aberration or alteration, I would call it, a disorder, we call it. So how do you do that? We can do by using magic bullets. That's doing a very precise medicine. Here, the molecular change that's specifically happening in that specific subject, if we can alter it, if we can block it and bring him back the subject to the normal physiological state, is what the goal of the treatment is. It can be achieved by looking at 3 P's, that is personalization. And these words are little bit loose in term, and you can see in literature, personalization, individualization, and precision therapeutics. It is, you need to keep in mind each individual is different, each individual's comorbidities are different, and these are some of this particular asthma is also a one set which is age related also, and these may be using the subject may be using the polypharmacy. So when you advise or when you counsel a medicine to a patient, you need to consider what the comorbidities are. You need to consider what all medication that subject is using, and you need to understand the kinetics and dynamics of each and every molecule. So you all know what drug does to the body and what body does to the drug, and the kinetics and dynamics. These 3 P's are very essential in understanding. And when you do in a Bachelor of Pharmacy or PharmD degree, you study physiology as one subject and pathophysiology as some subject, and under pharmacology you study one subject, pharmacotherapeutics as another subject. Now what we are trying to do in this webinar, we are trying to integrate, instead of as a discrete subjects, we are trying to integrate like a continuum and understand a disease, how to achieve optimal outcomes. So you understand the disease, you got the right medication, and now you need to give it to the right medication at the right time, at the right dose, to the right patient. So here 3 P's, very important is the pharmacist role. It's very, very critical, which is underappreciated in India. And I'm sure, and with the changes that with PharmD course that we have in place now, people will realize and understand the power and the value of the pharmacist and in getting optimal outcomes. And this is so important in asthma. And all the the pharmacy students who are presenting in this and the faculty who are presenting in this should start exploiting this and interacting with the doctors and interact with the patient, how and what a pharmacist can do magics or miracles to achieve optimal outcomes. Of course, physician is required and the doctor. The doctors are specialists in diagnosing the disease and pharmacist is specialist in the treating the disease, that is the specialist about the drug. And what is common between the physician and the pharmacist in education is disease understanding. And the amount of disease understanding that we do with this phenotype characterization and the precision medicine selection, especially the drug-drug interactions, which pharmacy students are so good at it, and they're using the softwares and studying various subjects at a time. Very wonderful course, and be proudly interact with the doctors and with the patients, saying that we are the experts of these drugs and you are expert in diagnosis, and we both have a common, which is disease understanding. So you see how much understanding that as a pharmacist one would have in this webinar, and how to interact with the patient, how to interact with the doctor in convincing that you want to achieve optimal outcomes, we need to work together. And these 9 P's should work together. It is not only these 9 P's, at the end I will add another 3 P's and another 3 A's, which are very essential to be even much more globalistic view. So I hope you all agree with me, these 9 P's are very important. In this talk, we'll try to address those 9 P's in each and the importance of each P in this treating asthma. And it is in general, it is true for any disease, but it's so much true for asthma. So in this seminar, what I focused is more on understanding this phenotype characterization, because that is the villain in this story, and the heroes are the pharmacists. And the more you know about the villain, very easy to handle, and naturally your hero will fall in the precision medicine, fall in the right place once you understand the villain character well. And that's why it's in red in color. Don't miss me as the villain, I also wear red color. And so with this 9 P's, we'll understand, and focus is more on phenotype characterization. And we do pharmacology. Being a pharmacologist, I'm very happy and glad to talk about the precision medicine. And this is a loose term, as I mentioned before, and the role a pharmacist can play in achieving this optimal outcome. So let me start with what is asthma, and many of you studied it and know it, but still it's my duty customary to introduce you that story. So it is a heterogeneous disease. So it is a disease caused by many reasons. Like this webinar participants are heterogeneous in nature. So we have different students, we have family, we have faculty, we have scholars, we have senior faculty, and we have some from industry. So it's heterogeneous in nature. So whenever it's heterogeneous, and whenever you start a treatment or whenever you give a lecture, it will not be uniform distributed. Different populations or subgroups take the content in different way, and I'm trying to cover every person of this person involved participating in this webinar. And so the treatment is different. That is first indication that this is heterogeneous. So if you give a most powerful immune suppressants like glucocorticoid, also some patients respond, some patients don't respond at all, which tells you that how much variation is there, which tells you how the subject of the disease is heterogeneous in nature. So now we'll try to understand this heterogeneous nature of this disease and try to address it with precision medicine. That's the goal of this approach. So the symptoms are associated with the variable nature. It's variable, as you see here, asthmatic subjects, unlike COPD subjects. Here also I try to address some of these lung-related diseases. Let's focus on asthma only. I know when I give lectures, I find that the participants usually lead to not the content of the periphery that we talk. So when you talk about this lung, I'm sure many of you are thinking about COVID. Yes, COVID is also leading to this lung disease, and but let us restrict to this for now to the asthma. So it's a variable because you see the asthma when subject is having this exacerbation, and you see it's very severe, but otherwise the subject is normal. It's absolutely a normal subject. You never know by looking at the subject. Unlike cancer subjects, we can say that this person is having asthma. He's absolutely a normal person. So that the symptoms do present and don't present, and some of the symptoms and the reasons that cause these symptoms of bronchoconstriction, As you can see in this image, the diameter of that bronchi or bronchiole is narrowed. And why it is narrowed? It's partly because of the influx of the increase in the thickness of the walls and influx of these inflammatory cells and so much of mucus generation in the wall. And because of that air outflow, this is more of a disease of affecting the expiration of the air outside the body. So it is not an issue with inspiration, it is an issue with expiration. So that's what it's called. It's an obstructive because the mucus is obstructing, and we do have diseases like ILD, we call it, and which is a disease of the influx where air getting inside is the problem. Here, air going out of is the problem. That is the reason the diagnosis that we do is the spirometry, where we try to exhale the air and determine the lung function. And here we need to talk, disease, we need to talk about the burden of the disease, asthma, and it affects approximately 5% global wise. 5% is big number. We have so many diseases, just one disease is about affecting 5% of the population. Almost is a huge number. It's almost 300 million subjects are affected with asthma. And as you see nowadays, because of the urbanization and we are removing the all the plants and the trees, and we are making all concrete jungles and removing actual jungles. So that leads to so much of pollution, and you see what is happening in Delhi. And we are changing the rules. We are asking them to share the facilities, don't use individual cars, try to do pooling and all. Of course, now this COVID has changed the picture again, totally different. So this is a very, very serious disorder. And in fact, if you look at the deaths worldwide and respiratory disorders in the top 5, and the major deaths that you see in the worldwide, globally, death rates are mainly due to the cardiovascular, followed by the cancer, followed by the respiratory disorders. And this respiratory disorders, and then further followed by respiratory infections. Respiratory infections is the 4th one. Respiratory disorders is in that asthma and COPD will come is the 3rd. And the 5th one is accidents are the leading cause for death. So that tells you the importance of asthma or the respiratory disorders. And this year, I think statistics will change completely. And that's due to respiratory infections because of the COVID will become number 1 or the leading cause of death of human suffering present scenario. And it leads, these numbers will be completely changing with this year. And the way the trends that's happening now, these respiratory infections or respiratory research has to go immensely in the coming years. And as you see in developing countries like ours, we are developing definitely, but we are also not taking care of the nature, and nature imbalance is happening, and it leads to more and more pollution. And the trend is very clearly that the asthma patients are going to increase in time. So that tells the importance of understanding the asthma. Are the students taking career in this asthma management of the patients, are doing research in asthma. And this is my 3rd webinar, which I was giving during the COVID period. And first one is about drug discovery and development on COVID, with some emphasis on COVID and some emphasis on career opportunities and skill sets required for the 21st century pharmacists. And the second topic is on cancer. Now we're talking about respiratory disorders, and maybe next month or so I'll do the COPD, another dangerous disease. Very, very, very important disease, and lot research needs to be done. Let's understand this, why it happens, how it happens, and we see how to manage the show. So here the way you do it, this is as you are studying now, it is expiratory disorder. So it's going air out of the body is the way you need to see, and the way it is done is using spirometry. So what you need to forcefully expire the air, expire the air, and measure how much air is going in 1 second compared to the total. So when you do the forced expiration within 4 to 5 seconds, and more, all the air that's present in the lungs will go out, and how much of the air that's gone in just 1 second, that's called FEV1, forced expiratory volume. 1 second divided by the total is what tells you the lung function. And whether it is reversible or not is tested by giving a salbutamol, and it is in Western world it's called albuterol. And when you give this, and it causes if the patient is having vasoconstriction and being a short-acting beta-2 agonist, it's supposed to be expected to cause vasodilatation, and so more air is expected to go out, and FU1 is increased, ratio is increased more than 80%. That's how you determine a subject is having asthma or not, whether that is reversible or not. If it is reversible, and you can know that the subject is having asthma, because symptoms and the causes that we see with asthma are very similar to many other lung disorders, including COVID. The symptoms of COVID are very much similar to asthma, because in fact it's a lung disorder. The symptoms that you see with tuberculosis, they do cause cough, they do have chest pain, they do have difficulty in the air pushing out. So and there are intestinal lung disease, another one which is also giving exactly the same symptoms. And in fact, even gastric irritation is also causes the similar symptoms, cough and heaviness and chest pain. You all see those symptoms now. And the patients, apart from the looking at the lung function, if somebody is having asthma, and what you see is their sleep get disturbed, and they keep on coughing, and depending on the frequency of cough, and depending on the sleepless nights, and depending on the use of the medication, because the disease is getting worse, and you need to necessarily tend to use because every attack, and we have a reliever therapy, which will go into the therapy part, later part. The subject is naturally uses the short-acting beta agonist to relieve the therapy. So basic, and also it affects the quality of life. If somebody don't sleep properly and coughing all the time. Now with the present scenario, whether subject is coughing due to asthma, due to COPD, and he cannot write the exam, and he will not be allowed inside, and so many things will happen, unfortunately, in this current scenario. So the disease severity is basing on the lung function, and basing on the symptoms, basing on the sleepless activity, and basing on how much it is interfering with the daily life. It's very, 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 very you don't want this disorder to your enemy also, because it's very disturbing, especially when it becomes so severe. So this understanding of the disease and the disease severity and understanding the lung function, we can mimic these situations, these conditions in animals, induce the asthma in animals, and we see those animal models also today, and try to estimate the lung function in the animals using technology. Now present technology facilitates to mimic exactly the same experiments that we do in humans, measuring the lung function. We do the bronchodilator activity with SABA, or we may do the bronchoconstriction activity, methacholine challenge is what is done even in humans to see the reversibility of the disease. That the subject is having asthma or COPD is tested by this lung function using an agonist, or using a beta-2 agonist, or a methacholine, which is a cholinergic agonist, which is more stable compound compared to acetylcholine, which was studied in pharmacology. So these studies will be mimic in animals, and you see what will happen in animals, and understand that the biology what happens in the cell. So now these are the symptoms you all know very well, and you know these are the causes, and you see the pets and the dandruff and the hair, the particles, and the dust and the chemicals and the mold, and the infection could be bacteria. The infection can be from the virus, or infection from even from the worms. And these are all the causative factors, and these are the causes that resulting into these symptoms. This is the cause and this is the effect. And in between, there is an underlying mechanism. And those underlying mechanisms is what we are going to understand in this webinar too. And how to exploit this. We know that in humans, we all know experience with the dust, we get the cough, and this is one way of protective mechanism. And same mechanism, the simple logics and the principles, you can apply and induce in animals, induce the disease, and understand those molecular pathways or endotypes, and devise the medications to address from the animals, and then slowly take it to the human beings. That's what this whole discovery and development of novel agents is. So we understand those mechanisms in the current slides. To understand more, you need to understand a bit of this immunology. I think all of you studied, we are pharmacists. Let me remind, we have an innate system and we have an adaptive system. And in innate system, we have players like granulocytes. the name is granules are present in those cells. You can see those spots on these cells, like basophils, eosinophils, and mast cells. And when these get activated, degranulation is the process happens and releases. So why all this immune system is present in the body? It is all with the way skin is being there on the body, protective from the external environment. So we have our inside the body. These immune cells are the protective mechanisms. So when do we have an external stimulus or external challenge or external virus, the way we see it in COVID, when it enters the body, and the first cell that gets addressed is this bronchi and that epithelial cells. And they start releasing the alarming signals that leads to the activation of these immune cells. And these immune cells have a different strategies, and the neutrophils are the phagocytic in nature. They are professional phagocytic cells, and same way the dendritic cells, they phagocytize that bacteria if it is a virus, and try to kill that bacteria or virus. That's how these neutrophils starts doing their job. And the eosinophils and the basophils, they release various enzymes and proteases, proteolytic enzymes, and start trying to kill that bacteria or that virus, whatever it is. Same is the case with natural killer cells. They are natural in nature. They don't need activation. They don't have T cell receptors, and they do that job in a similar degranulation, and by other means, mechanistic way, they address that external challenges. Same is the case with adaptive system. Here we have the B cells and T cells, and these cells to work, they need to be activated. And B cells do the job by releasing antibodies. And so we all know about this antibodies, and B cells get activated and become the plasma cells. These are the one antibody producing cells. They releases antibodies. These antibodies go and attach to the antigen present on that and facilitate the antibody and cell mediated cytotoxicity. And whereas the T cells, these are two types, cytotoxic T cells and CD4 T cells. These T cells releasing the cytokines, trying to address that. And what is interesting phenomena is this innate is very fast in nature, and it is highly non-specific. And every time that virus comes or the bacteria comes inside the body, then they seize the lung. Same occurs happens again and again. And it is very rapid, but it's not sustaining, and it doesn't have any memory. And in adaptive system, it is very slow in nature. It takes about few days. That is the reason you see on the viruses also gets in to find the virus or to see whether the subject is responding or not. It does take time. That's why incubation period is critical. In that period, if the immune system starts working, the virus may not proliferate and is under control. That's what's happening with this COVID also. So this is very antigen specific, and it has a memory in it. Means it's long standing. So in a way, it is like in any class. So you have students which you can classify as innate and adaptive. Those who study for every exam, and any question that you ask, they write the same answer because they know that much only. If there's a question I'm asking to write pathophysiology of asthma, whatever the asthma that they study, they write that story only because they know that much only. Every time, whenever there's an exam, they study, and it's very fast, and they forget. And again, next exam, final exam, again study and forget. That's like innate mechanism, innate immunity. Whereas adaptive, these are the students who are good students. They study on everyday basis, and when the question comes, they write pathophysiology. If you ask, they write exact pathophysiology of asthma. So they are very highly specific and they have long-term memory. So you can classify yourself, you find yourself in relate to this, and some are phagocytic, they don't study and they don't allow others to also study some kind of neutrophil action. But remember, all these immune cells are there to protect you. This is a normal physiology when there's an external stimulus happening. But unfortunately, what happens is these cells get stimulated and start killing the bacteria or the virus, but it also leads to excessive activation and results in inflammatory reactions. That is the reason we are finding the disorders like asthma or COPD, or the changes that we are seeing with COVID-19. So our virus is immune system is trying to address that virus, but during that time, these get activated and they are producing this inflammatory soup, and that is being uncontrolled activation, resulting into all the side effects. That's the reason this is called an autoimmune disorder. So this immune system is trying to address that, and because of this immune system is overactivated, and this immune system is resulting into those side effects. That is why you have this respiratory depression and leading to death. So if you want to go and how much specific our human body is, how intelligently probably God has made. If you see these T cells are the ones which are activated by these dendritic cells, and then these are being become effector cells depending on the inflammatory soup present in that environment. And these effector cells are many types, Th1, Th2. So Th1 is more of interferon gamma, and it is the TNF, and the Th2 is IL4, IL5, and IL13. As you all studied in asthma, is a Th2 type disorder, and where you see that Th2 cells, the effector cells, are more in number and releases these cytokines IL4, IL5, and IL13. So you see those functions. What happens is, so when you see an allergen, as you see in that right side, it's a very nice slide. It's like central dogma of our immune disorders. We can expand from this. So if there's an allergen, so that is the allergen which is acting on this epithelial cells, resulting into the alarmin signal and releasing into the cytokines. And that allergen is being taken by this dendritic cell, and these are because they're phagocytic nature. And the one beauty of this, they also have antigen presenting skill. That's we call it as the professional antigen presenting cells. So they present that antigen, and antigen interact with the T cell receptor present on the T cell, resulting in the T cell activation. And this activated T cell further differentiated to Th22 because of the allergen is releasing, and which is the stimulus which is happening at that epithelial cell is releasing the IL4 and the other immune cells that is present around that epithelium, resulting into the Th2 type. That's how specific that Th2 is. So in fact, the T cells that is present in each individual, depending on the way they expose it to the pathogens, it could be bacteria, it could be virus, it could be nematodes or worms, or it could be the environment pollution, it could be polar grains, it could be the skin scales, and it could be dust, it could be many things. And a specific reaction happens, a specific T cell type will get synthesized, and that tries to address that. So just to see that example of Th17, so if it's mucocutaneous sites are being addressed, and you get the Th17. This is something you see with smoke, cigarette smoke, and this is something you see with ozone exposure. This is something you see with some worms that exposed to this mucocutaneous sites. Nothing but that bronchi and that epithelial cells present on that. So that's how each individual T cells are different, and they express the markers on their cell surface, and based on these markers, we identify in the blood of the bronchial alveoli that you take in experiments and differentiate which T cell type is present under a given challenge. So understanding this biology is what we apply. All this knowledge as biology has come from studies on experimental animals, and these principles we challenge the animal with a specific allergen, and then see and what happens to the lungs, what happens to the T cells, what happens at the lymph nodes, what happens at the bone marrow, what happens to the different cell types that's present in the blood and that present in the bronchial alveolar lavage. So there's a beauty of doing research, and this understanding will help us in defining the patient having this phenotype because of this endotype. So we'll see this, how we do in animals in labs, as this is something for research scholars. And this is, as I said, I'm more of a satellite view presentation. I'll be very happy to address you at microscopic level because I have done this work for a long time, for many years. And any specific question at the end, if you ask, I'll be happy to answer. So here is one challenge that we are talking about, chicken albumin. So when inject, and there is two phases here. One is a sensitization phase, or is a challenge phase. Sensitization phase is where you are giving this allergen, in this case albumin, to the animal by the intraperitoneal route, and this is what makes that effector cells set ready. Means by giving albumin, and it is activating this epithelial cells and releasing the alarmin signals, and that is happening with and then dendritic cells taking this antigen and processing it to the T cell receptor present, and resulting the signal 1 and signal 2, which you will see at later slides also, resulting in activation of T cells, and these cells further activated to Th2 type, because this specific mouse strain is biased towards the Th2 type because of the environment that is present in the lungs due to the stimulus of this ovalbumin. So when you give this ovalbumin again, that is by intranasal route in this case, on the third week, that is like a challenge. This is how you see in asthma patients are absolutely normal, but they already seen that asthmatic attack before, when the again that allergen they see it, that is the time they see the exacerbation. That's what asthmatic attack. You can know how the patient will have trouble in having an asthmatic attack. That attack you see it very fast because the initial attack is the one which is resulting into these effector cells ready, and now whole process doesn't need to take place. Just that second challenge that we give, that is the third week treatment that we're giving in animals. Same thing in humans that happens when you see the second time that particular allergen, because T cells are already active. There are armies or thousands of T cells are ready to interact with that instantaneously, resulting into immediate activity, resulting into respiratory difficulty in asthma patients. So this is what is being observed in animals, and actually from the animals, or it's a reverse translation. So what do you understand, what do you see in humans is what we try to do in animals, or what do you understand from the animals we try to translate to humans. So in this case, ovalbumin, and it's present from the chicken egg, and it doesn't happen that when you eat the eggs, you do get asthma or you get asthmatic attack. So this is not something which is mimicking in human, but it does have the similar mechanistic reasons that you find it here. So another model is house dust mite, and many of you can very easily imagine that importance of house dust mite. And house dust does cause respiratory difficulty, and because of the mite that you see in this image, that's present, and this mite extract is present in the market. You can buy it and give it to the animals by the intranasal route, and they do develop asthma. And wonderfully of studying, and in this model also, we see the eosinophil levels goes up, and this is more of a eosinophilic asthma. And this is sensitive to the steroids. And now another model, Galimpic. Galimpic is most sensitive species, and some of you might have studied in your college, or those who are seniors who are part of this might have did the experiment, tracheal chain and histamine, and because most sensitive species and very relevant to the human situation. And these animals, when you give ovalbumin, also develop asthma. Very beautiful experiments, because you can't do these experiments in humans, because here at the end we sacrifice these animals, we take out the lungs, we take out the lung contents, the soup that is present, that inflammatory soup, and you see the pathology of the tissue that happens, what happens to the pathophysiology, how the inflammatory cells are accumulated, what type of cells there, and how much numbers are there, what cytokines are present in that environment. So much mechanistic studies one can do, and this understanding helps in devising that precision medicine. So next is the brown Norway rats. These are very sensitive. So when you give ovalbumin to them, and you can see that wheezing sound just by going near to these animals. Just like the humans, when you have this mucus lodged in this bronchi, and there's a wheezing sound you get. These animals very typically develop that. You don't just go and stand beside them, or in that room also you get that sound. They develop very easily, and very sensitive model, wonderfully of testing the drugs against allergic eosinophilia. So basing on these molecular mechanistic studies, which I am not going to deal, we have done several hundreds of experiments, thousands of molecules are tested in these models, and I'll be happy to answer any of the questions that you have at the later part. So this understanding helps in defining the physiology or pathophysiology that happens, and can address decisively with precision medicine or precision drug, which can alter that molecular pathway back to the normal. So with this understanding, the technology that is applied is using this. So the bottom ones are the ones probably most of the students are actually not able to see it, but these have been there. We are working with these equipments, the Flexivent. This is one instrument where you can use the way you are testing, like it's indirect way, you can say, like spirometry that you have done in humans. This is a study where you can do similar lung function studies in animals using this Flexivent software. This is a very wonderful instrument where your trachea is connected to the cannula, and with the peristaltic movement, we generate like artificial, the way we are doing for the COVID patients now in hospitals, artificial respiration. Here we are connecting and see the lung function, and we challenge this with the various technologies. So the drug will push into the lungs, and then with space technology, and then lung function can be measured, various parameters, various measures. There's so much of physics and biology involved in developing this technology. And this is from Montreal. This is the technology was developed at McGill University, where I did my postdoc. And the company is in Montreal, and I've seen this company. It's a wonderful equipment. That's the gold experiment. Of course, we can't do it in college environment, but if you do some advanced work, and many people try to help you doing this. In India, there are many devices, many institutes do have this facility. And the next one is Bucksco. This is very old one, very common, more popular probably than Flexivent, but it is not as gold standard as Flexivent. And I would suggest if anybody is interested in asthma research to go for this Flexivent. And the next is InExpose that you see it here. And this is that the one image that if you see it very clearly, this is a cigarette smoke exposing equipment. You can that the cigarette smoke is one cause for this all over respiratory disorders, and you see that liver diseases, lung diseases that you feel, lung diseases because of the exposure of the cigarette. You get lung cancers. We all know it, and this is all that you can test, and you can also see even to expose this external environment challenges, gases, substances, or cigarette smoke. You can use this technology equipment to expose the animals to the lungs and find the lung functions, understand these molecular mechanisms with that. So with this understanding and lot of studies, permutation combinations, the humans have been characterized, and this is what we can characterize the disease as mild, moderate, and severe. And as you see in this image, in the severe, you might see that the thickness is increased. There's a fibrosis, and there's a lot of initially you see in the mild situation, eosinophilia, and in the moderate severe asthma, you see neutrophils. That is the time your steroids don't work, regular medication don't work, and our focus is severe asthma. This is the latter part where you see that hyperplasia of the smooth muscle, and where you see the fibrosis, that's collagen deposition, and where you see huge mucus that you see it at the top layer as a blue lines. And this is all this exposure. This is where much research is needed. There are about good number of percentage of patients are there where the current medications, the best are the best medications, even when used in combination, they don't work. And patients, some of them do die because of this severe asthma. So our focus in this talk is more on the severe asthma, and basing on the understanding of those animal studies, and these patients have been characterized. So we're not going to each and every detail. As you see it in this image, that allergen is there in left part. Let's focus for time being. So when allergen exposed to this epithelial cells, and these alarming signals, the IL-33, IL-25, TSLP are released, and your allergen is being taken by this dendritic cells are infiltrated. There is a leakage happens in this epithelium, resulting in the fluid content or the movement of these inflammatory cells into this lungs, and those ones are trying to take that allergen and process this as antigen, reacting with the T cell receptor on the T cell, resulting into TH2 cells. And TH2 cells in turn, these effector cells releases, as you see in the earlier mechanism that immunology that we discussed, releases the IL-13, IL-4, and IL-5. And IL-4 and IL-13 are excellent cytokines for activated B cells, and activated B cells are the which releases antibodies. These antibodies are which are going to interact with the mast cells, and mast cells major function is releasing histamine. Histamine is a powerful vaso bronchoconstrictor. So once it causes constriction, you have that difficulty or lung function get compromised. And this IL-13 also plays a very important role in the smooth muscle proliferation. It plays an important role in differentiating these epithelial cells into goblet cells, which are nothing but mucus secreting cells. There are more mucus secreting cells compared to a normal subject, a normal person, and this leads to the more mucus formation. And that is this particular allergen associated the cytokine storm and associated this antigen, that antibody formation from B cells. We call it as allergic eosinophilic airway inflammation. So this is the allergy is the one which is driving, and here Ig levels are high. So if that is the phenotype, we see it, and we call those subjects are having TH2 high inflammation, or the TH2 cells are activated, and because your Ig antibodies are more, and these subjects you need to treat with IgE antibody, that's omalizumab, which we see at later the pharmacology. So what is seen in the humans or subjects is that this is something that you see is an early onset asthma. This is usually you see in the kids, generally the kids that you develop asthma, they do have this asthma. They are usually having high IgE levels. Most of the reason for them to develop asthma, the young children, is because of these allergens, because many of them are exposed to the dogs and the pets, and that's one reason. And many other allergens, they're very sensitive. Their immune system is not well developed, and they're prone to develop this allergen. And of course, 50% of subjects do have these allergens, those adults do, but the number is about 50% only. But most of the children that you get are usually allergic eosinophilic asthma. And these subjects, no issue because they respond very well to the corticosteroids, but you know the disadvantage or advantage of corticosteroids, that the most powerful immune suppressants, they do definitely suppress the system, and you get a very good relief, but they do have some leakage, though you apply by inhalation into the systemic circulation, and that result in the glucocorticoid associated abnormalities. So definitely, if you use the glucocorticoids for a long period, the subject may be relieved of asthma, but he may be developing syndrome of diseases. It includes diabetes, it includes obesity, it includes body weight gain, so many complications. That's why it's not the best, but the goal should be discovering medicines which reduces the need for replacing the glucocorticoids, which are more safer. But it's a big goal. So some subjects, as you see to the right side of the image, please focus now on the right side. And here the immune system activation is microbes or glycolipids, and it could be cigarette smoke, or yes, that cigarette image is also there, or it should be ozone exposure. So the stimulants are different, and why these get differential stimulus? We call it as, if you want to talk more molecularly. So these microbes carries the pathogen associated molecular patterns, we call it, and once they interact with the PRR, we call it pattern recognition receptors, which are like toll-like receptors, we call it, and once they activate those receptors present on these epithelial cells, and it's the inflammatory pathways, the toll-like receptors, NF-kappa B, MAP kinase pathways are involved, and there is a very complex pharmacology of toll-like receptors. There are about 9 receptors, subtypes, and each one resulting into different cytokine environment. So that's how those cytokines get released, and these cytokines can directly interact with another cell that's called ILC2, innate lymphocyte. It's very new knowledge. If you see the books of the past 5-6 years past, you don't see these images. This is very new, and these ones doesn't need that antigen presentation by the dendritic cells. They directly get activated and release the similar cytokine like IL-5 and IL-13. They also get activated by the prostaglandin D2, which is also usually released once mast cells get activated. That prostaglandin D2 acts as TH2 and resulting in the release of further cytokines and complicating this phenomenon. And this molecular mechanism happens usually in the adult patients. That's why it's called late onset asthma, and it involves both the TH2 and ILC2 pathway. The way we have seen the TH2 pathway, TH1, TH2, TH17, TH9, TH8. So even innate, now the present knowledge is there are 3 types: ILC1, ILC2, ILC3. ILC1 is like TH1, releases interferon gamma, whereas like TH2, ILC2, as you see in this image, releasing the similar cytokines, that is IL-5 and IL-13. So in the later stages, you see that IL-C3 plays an important role. It is very similar to TH17 cells and releases the TH17, that IL-17 and the IL-22. So this is what we call it as non-TH2 inflammation. And here, as you seen earlier, that the eosinophils is not the one, the neutrophils are the major culprit, and the neutrophils are get influx, and they do that, you see the melanocortin release, and in all experiments, we estimate melanocortin and a direct marker for neutrophils, right? So that's what we see here. So that cigarette smoke and some of the bacteria or the viruses are the ones which resulting in the pathways that we discussed, resulting in TH17 or TH1 or ILC3. So earlier we talked about TH22 pathway, now we are talking about the TH17 pathway, and resulting into the IL-17, IL-22, which mainly recruits the neutrophils. And this type of asthma is very common. This is about 50% of the subjects, and it is very difficult. It is insensitive to the corticosteroid treatment. So even if you take inhaled corticosteroid, these subjects don't respond. This is where the about good number of patients are present. This is where the treatments are challenging for the patient and for the doctor and for the pharmacist. So this is where we need to see. So there are various ways of estimating it. These are very easy technologies. Is one good equipment, very is a handheld. You can just go estimate the nitric oxide, which is a marker for that history information. So basing on, if you summarize, I think the villain part of the story that is we can classify asthma patients in humans as having TH2 high and they are early onset and they have high eosinophil and they are CS responsive. So when you go to the tier 2, where we say, as you see the earlier slides, if you are compiling, and it's more of later age onset, that means those most of you are now at adult, and if somebody is getting, it's most likely that it is a later onset. And here you see neutrophilia, and in good number of this eosinophilia also. And it is the cells that we see it high is the TH1 type and TH17 type. And is usually seen when somebody is having smoking habit. So smoking is injurious to health, and it is one good example. Those who smoke, and if you have asthma or COPD and any respiratory disorders, the best and most important thing to do is stop smoking. And obesity is another reason which you see that late onset. These are the two associated or comorbidities, or these are also the cause in a way to develop asthma in those subjects. So the best way is treat asthma and treat that underlying phenomenon. So with this, the villain part is done. Now easier part. Now we understand that phenotype or the endotype of the subject. Now how to come up with that device or strategy which can effectively treat those patients. In earlier days, about 10 years back, if you see the literature of diabetes, also the treatment is by classify subject as stage 1, type 1 or type 2, and having a flow chart, just follow the flow chart. Now present strategy is not that they have to go by not one fit for all size, one size fit for all. You have to identify the subject as an individual, and you have to personalize the medicine, looking at the comorbidities that is present, looking at the cost factors, looking at the how much money you can spend, how much convenience that you want in treating the patient, and what all additional comorbidities, what are additional medications is taking. So there's so many factors that needs to be taken in coming up a strategy in treating a subject. And unfortunately, our doctors don't have the time to understand the subject. And this is something which all the pharmacists, we as pharmacists, should go and tell, we are not competitors, so we are cooperating with you, and we'll help your time, we save your time, we are experts in drugs, we give you the best of the best medicine for the subject, we save your time, let's work together. So the goal in this therapy is in asthma is definitely is to minimize, once you treat asthma most appropriately, then hospital visits will reduce and hospitalization costs will reduce. If you see the challenge with the COVID, the biggest challenge is the hospital visits. You see how governments are failing the system right now. Because once you go to the hospital, if you see the bills of these COVID patients, the treatment cost is about 400 rupees. And actually the patient that comes out after the 14 days of the treatment, usually treatment is 5 days or 10 days. And when it comes out, it's 4 lakhs. So drug cost is nothing. Hospital cost is too much. So to minimize those hospital costs, the best approach is to take the medicines properly, appropriately, and take the right medicine. That is true for asthma. That is true for any disorder, and especially the life-threatening disorders like these ones. You need to, because life-threatening, people sell all those properties and get the treatment done at that last 10 days. So what we need to do is we need to educate the patient, educate the family that taking medication appropriately is very, very essential. Otherwise, you end up spending all your earnings in just few days to the hospital. And this is how the hospitals are now exploiting also. So now the strategy is to maintain the normal pulmonary function, maintain the normal activity, provide the optimal therapy with minimal side effects. This can only be done by a good pharmacist. So now this is GINA is Global Initiative for Asthma. These are the guidelines how to treat a patient The way you start with is ICS with formaldehyde, and if you see the guidelines I'm seeing is in colleges, and what you are studying in the textbooks, those books are written about 10 years back, and by the time you order it, by the time you come to the library, it takes another 2 years, and by the time faculty reads and start teaching next year, and by the time you start teaching, that is become outdated. And my sincere request to all the faculty is don't rely on this best of the best textbooks. Also, rely on the global societies, which are you go to these websites and it is freely available, and there is an educational material available, and try to teach the students the latest of the latest information. These guidelines, especially for asthma, are revised on every year basis, and the beauty of these guidelines, they do give why the guidelines have been altered, the treatment strategies altered, what is the evidence for that, what studies has been done, what study is telling to change that the treatment paradigm. So that much rationale is given. That's the wonderful of teaching, and the students are those who are doing research interested. They should know the latest of the latest information, not this good old so-called textbooks. So here the treatment strategy is combine a steroid with a long-acting beta-2 agonist. So earlier days, you see the same last year itself, this is not the strategy. This has changed. So this has been promoted, ICS formaldehyde. So as the disease get worsened, you increase the dose of the inhaled corticosteroid, that's step 2, step 3, and then further that's medium dose, that's step 4, and step 5 is even after using corticosteroid with the LABA, long-acting beta-2 agonist, which is a bronchodilator, and which is an ICS is the anti-inflammatory agent, the best of best combination is given. Still, there are patients which are not treated effectively. These patients are called severe asthma patients. Today's talk is all focused on those subjects, how to address those subjects. So by definition, so if anybody is interested in asthma, these are the sites that one should go: ATS and DRS, American Thoracic Society, and European Respiratory Society. They defined severe asthma as subjects who are taking inhaled corticosteroid high dose plus a controller therapy and are systemic means oral corticosteroid. So even after taking inhaled corticosteroid and additional treatment, many patients are not treated enough, and they do have complications, and we need to address those patients. This is severe asthma. These are about 5 to 10% of the subjects. Even of the latest that's available in the market, if used, there are 5-10% subjects which don't get sufficient relief. So there is a need for research further and get the best of the best medicines. So these are the some medications in corticosteroids. You see it here. Here you see as a dual combinations ICS LABA. You see in the market triple combination ICS LABA and LAMA that is used for the COPD, not for asthma. And there are so many glucocorticoids available and so many types of devices available. It's so confusing. It is just impossible for the doctor to suggest or treat or guide a patient. This is the time doctors need desperate help. This is the disease where doctors need desperate help. This is the time where the pharmacists say that we are the experts and we can help save your time, we can save your money, and because we can work at lesser cost and give the optimal treatment for healthcare. So the burden is for the whole system. You see, who is being suffering with COVID? All the subjects. How much money is being spent on hospitals? And who is getting money? Those who have money. Hospitals are put up by those so-called so rich people, and they have become richer and richer. These people have become poorer and poorer because they are not taken proper care. So this is where mass education is important, and pharmacists can play an important role. And I can't emphasize more than this. So now, with this subject is having a high allergy, and this omalizumab is one where you can give because it goes in interact with the IgE, which you see when it's activated B cells are releasing this antibody, which is interacting with immune cells, and these immune cells are the one releasing and resulting some treatment affecting that antigen as well as resulting to these complications of asthma. This can be treated with Zolai, and this there is a 5 years research data also. So you see the antibodies usually develop to these antibodies and resulting in compromised efficacy, but there is 5 years data saying that they didn't develop even after continuous therapy, that resistance, which is one common problem with many of the antibodies or even many of the pharmacological agents. So the beauty I like in this is here you're looking at this y-axis is reduction in exacerbations. There is number of asthmatic attacks, and on the x-axis you see number of eosinophils. The more the eosinophils, the blue bar is more. The percentage reduction is the one. So the more the effect. It's very beauty is very rare pharmacology. The more the disease or the severe the disease, the compound is working better. It's a wonderful thing. It's not normal happens. So it is something like work hard and you get the highest salary. Not all people who work hard get the highest salary, right? So most of the drugs also don't work that way. So if the disease is severe, they don't work actually. But this is beautiful thing, and I like this phenomena. This phenomena has been reported in many other diseases with the GLP-1 agonist in diabetes, which has been claimed to produce insulin-dependent, glucose-dependent insulin secretion, more the glucose, more the insulin secretion, and better the activity. So this is something we teach. I teach pharmacology. So the higher the levels of IgE, the higher the levels of eosinophils. That is the time this normalization works best. This is the endotype. This is where how to treat this subject. But where anaphylaxis, complex issue is there with this, you need to take care. And you need to go ready with the epinephrine. So now is that other therapy, and this is also useful for the same issue. That is eosinophilia high. Eosinophil levels are so high. IL-5 therapy is the best therapy. And how there are two types are there here. Nebulizer and reslizumab, they go and interact with the circulating IL-5, these antibodies, who call it neutralizing antibodies, such ones. And benralizumab, the name has RA, that is the receptor agonist. So it goes and binds to the receptor, so that IL-5 cannot go and interact with the receptor on the immune cells. That's how they stop that interaction. These three and the two, and these are subcutaneous injections. Pens are available, and whereas reslizumab is an IV, so it has to, the subject has to go to a hospital for getting the treatment. But and the additional reason for that too is the subjects are likely to develop anaphylaxis with this drug, unlike the mepolizumab and benralizumab. This is the compound specific phenomena, and so that's one patient inconvenience. But the auto injects are very easy. Now people are all over the world are using for diabetes insulin injections or GLP-1 injections, which is auto injectors, which are painless, but they do cause local site reactions. There's a complexity. So we need to take into consideration in devising the right medication to the right patient and convince that these are the effective and needs to be done in right way. So the additional thing that one need to take care, these are being approved with the specific basing on pivotal trial, we call it as a phase 3 trial. And whatever the phase 3 trial is done, basing on that approvals are given by regulatory bodies and different countries. And in this case, nebulizer was done more than 6 years, reslizumab is more than 18, and Nagaraju more than 12 years. So as per the label, we are not supposed to treat reslizumab those who are like kids, because it's tested in more than 18 years only. And what the beauty is this, they're all working nicely, and they're improving the lung function, they're improving the quality of life, they're decreasing exacerbations, which is that that acute attacks that one would get, and also decrease the oral corticosteroid dose. And if you can reduce the oral corticosteroids, you're reducing side effects. It's a wonderful thing. But there is no head-to-head studies, so we are not sure which one is the best. So the patient's convenience and the cost, because IV is something all don't like to take, and sub-Q can be done at home. So there are so many things are there in this which needs to be considered, which can be told by a pharmacist only, which is expert. The another compound is dupilumab, IL-4, IL-13. There's a lot of mechanism. So the beauty of this is earlier ones, whatever we talk, they are specific cytokine. But this one interacts with two cytokines. Why does both IL-4 and IL-13 is that there is a common element, IL-4 alpha, as in the image on the right side top. The image, the IL-4 receptor has two receptor dimer, and IL-13 also two dimer. It has IL-13 R alpha 1 and IL-4 alpha as the two units. And so this antibody interacts with IL-4 alpha. So it interacts and blocks the activity of the, stop the interaction of the IL-4 with the IL-4 receptor, or IL-13 with its receptor. So it blocks the both. It's very effective. And studies have shown that this particular compound even works, reduces the need for the oral corticosteroid. Oral corticosteroid levels are seen on the right side bottom of the graph. So and reduce the dose of steroid, the compound still working. So wonderful way. It's very good. It's very good advancement. It's a very good news for the patients. And this compound is also coming up as a pen, as you see it in image. So now how to treat? So if somebody is having high allergy and eosinophilia, then one would go for the anti-IgE, IL-5, IL-4, or if the allergy is very high, anti-IgE, and if, only eosinophilic asthma and IgE levels are out of order, you can use IL-5 or IL-4. Most important is the bottom one, because somebody is already taking inhaled steroid and also taking a combination of LABA and also oral corticosteroid, which needs to be taken for some subjects, because though we call it asthma as a disease of the lungs, but there's a systemic inflammation component involved. So if you take oral steroid, it affects the systemic as well as the local. They are likely to work the best way. So, and studies have shown, the pivotal studies or the phase 3 studies, that if you take this one, you can reduce the oral steroid. So if you can reduce the oral steroid, you're reducing the side effects. It's very good news for the patients. That's what is needed. So when you, this is basing on this phenotype or the endotype, this is what that we are doing a precision medicine is. So with this, as you can see in this image, and compared with all the monoclonal antibodies and looking at the cost, looking at the convenience, looking at the side effect profile, looking at the complications the patient has, comorbidities, one need to select and guide counsel the right medication. And if somebody is very kid and then IO options will work, so we have Montelukast, that is actually the name has come from Montreal. This is another contribution for asthma from Montreal. You have seen that Cyrec company and that instrument Flexivent is coming from Montreal. This drug was done by Merck and at Montreal, and that's why the name has been Montelukast. The beauty of this is recent data that it was tested even in 1 year old. Likewise, this is a oral drug. You can mix with the ice cream also and give it to the subject. You can put it in a carrot juice or apple juice and give this medication. So even for the kids, this can be given and wonderful way of treating. Of course, in the latest recent information by FDA, it does develop psychological disturbances. So one need to be cautious in using that medication. So this completes that precision medicine strategy. Now comes the good news for the family students. So where patient education is key to success, because all this, the patient mindset is, when you give a medication which is very costly, they think that so I'm paying more, I'm taking the best of the best medication. Now I'm taking it, so I'm free of the drug, free of the complications. And though they know that for them beach is not suitable because some allergy is there previous, but they do go there because they feel that I'm taking medication. It's like diabetic patients taking a sulfonylurea and going for a marriage party. I see many diabetic patients. They cannot control their emotions, and they take the medication as if they are not taking, and they go and take party. So that's how this mindset is usually of the patient, and that the doctors don't have time to teach or educate the patient. And the pharmacist is the best person. We are the drug experts. We know about the drug more than the doctors. Doctor know more than us in diagnose the disease, and both know equally about the disease mechanisms. What pharmacists can do, you can imagine, we are the ones who are discovering the medicine. We know the history, we know the before the birth, after the birth, and in the lifetime about the medications, because you are there from the beginning. And some of the pharmacists are the ones who are devising these medications, making the formulation, coming up with these technologies in delivering the inhalation. Doctors, I'm not sure how many of them are really aware of these technologies and what basis and what logic inhaled therapy was designed, which a pharmacist can understand very well by talking to a fellow pharmacist. That's the beauty, that is the strength that we all have. We should utilize it, and we should communicate with the doctors, communicate with the patients. We are the people, we can save you, help you. So in this, the realistic expectation is the biggest thing, and which needs to be done. So these, though antibodies we are talking are so specific, so strong, very strong pharmacology, excellent specificity and minimal side effects, but we need to understand that they do take time to respond. This is a chronic disease. It's a disease that present for years together, and we don't expect the magic to happen in days. So these biologics, though they work, as you seen earlier, some of them are every month for every 4 weeks, and some of them are every 8 weeks. So you need to give at least 4 doses to see whether it's responding or not. So if it is responding, it's well and good. And this is one beauty area which I see in asthma, unlike other diseases, is that the guidelines also suggest that reduce the dose of medication. But another guidelines usually say, you give this one, you give this one. If it doesn't work, we add this one, we add that one. You see in diabetes guidelines by European Association for Study of Diabetes and American Diabetic Society. Okay, both are given the guidelines which says that okay, if the HbA1c goes more than 9, add triple therapy. If it doesn't go more than, add insulin. But no one talks about if it's responding, it comes back. But it doesn't respond well also in diabetes. But in this case, if you do it properly, you can reduce, you can alter the medications, you can revise the strategy and minimize the side effects and get the best of the best from the patient. So this patient education is so critical, so important that we all should try to exploit that in this current market. We should tell to the regulators, and whenever conferences happens, we should go and talk and say that we know this is how we can add value to the healthcare system. Now comes the beauty part, and unlike other diseases, this is the disease having many complications. We are talking about the best of the best combinations, we are talking about the triple combinations, but still what happens? It is purely controlled in a good number of subjects. Why it is purely controlled? If you do the investigation, major are 3 issues, medication issues. So the patients don't use well adherence, they don't adhere. They are supposed to take, say every day, inhaled corticosteroid. They don't take every day. Say there's an exam is there, okay, they get stressed and they focus on that, they forget about it. And suddenly they get acute attack and then start taking medication. Again, the few days they stop it. Again, they get an attack. Then they remember, oh, I'm getting attacked because I'm not taking medication, which they need to take as a controller therapy. They take reliever, they take because there's a problem. But controller therapy, if you take, you don't need to relieve. There's no question of exacerbation. But that mindset that doesn't happen. And if you see the prescription filling by the community pharmacist, the patients who advise these treatments, they take the filling for sure for the first time. They use it, they see it's working, not working, and that. But they need to know that they need to take at least 4 months of the treatment to see really it's working or not. That much patience nobody has. And this is, by the way, it happens once in a time. It's not something like COPD persistently present. It's not something like the lung funds that are affected with tuberculosis, where it is present all the time. It attacks once in a while. So the patient don't use. The adherence is the biggest issue. And the other biggest issue is the inhaler use. This technology is so good, but at the same time, they're also challenging. And there are more than a dozen of devices available. And each device is a different principle and different way of using it. And that use, the doctor doesn't know, even the patient doesn't know. Patient feels that he's doing right. And there are situations happens in case studies that patient, that there is no medication, he is still using it again and again. So the biggest problem is that medication issues, and that is a challenge for us. And the biggest challenge for doctors is that associated disorders or comorbidities that's present. If the comorbidity is so high, obesity is so high, or gravity is so high, or anxiety is so high, then the medications asthma don't work well. In such situations, you need to advise the patient to treat obesity also well. Not only, please keep those additional complications under control. If you don't control them, no matter how well a good pharmacist are counseling the medication, how well a physician is counseling the patient, no matter how well the patient is taking, but you know, these also can contribute or worsen that asthma. So that's how life is complicated. It is like putting so many exams for students. So you need to study all subjects. If you are very good at one subject, it's not sufficient. And as you see in this talk, you see that you need to study physiology, you need to understand pathophysiology, you need to understand microbiology, you need to understand the pharmacokinetics, you need to understand biopharmaceutics, you need to understand patient psychology, so many things. I need to understand the cost factor, financial management. So many things are there, and then only the meal is complete. Then there is a 5-star. So you need to have that knowledge. That's the reason you have all this in the subject. There is a lifestyle. So this is something which can be done, but it's very, very, very few can do successfully. Smoking is a very tough thing. It's not good for asthma. They know it. Everybody knows it. His family members knows it, but they don't stop. Patient don't stop. But then how can your medication expect to work? So these are certain things. Education can be done, should be done by the pharmacist. So if you see the numbers, the suboptimal adherence is common in more than 50% both children and adults. The children, the issue is this, especially if you use these devices. Children, as you know, they like to play, they want to take the medication properly, and some parent has to do some supervision. And nowadays, parents are also busy with this mobile technology as disturbing the children. Children are forgetting while playing games, taking medication, and parents are so busy looking at mobiles that forgetting giving the children. Forget about children, adults are also not taking. Adherence is the biggest issue. This is the where pharmacist can play an important role. The next biggest issue, as we see here, poor inhaler technique. So don't know how to use the inhaler, and is 80%. So you are spending money, you are taking the best of the best medication and the best of the best counseling. You are going to the best hospital, you go to the best physician and paying the highest fees, medical fees, and taking the very costly medications. Some of the medications very, very costly in India too. So, but they don't work because they don't know how to use it properly. So this is where pharmacists can play a role. Here I'm showing the DPAs, we call it as here that you need to do is a quick deep breath. So people learn what is quick, how much is quick. Of course, first time when you say it, they do it properly. When they go home, and somehow is like waking up in the morning and study well for exams. We don't attempt one day you stop it and some bad habit, next time you cannot make it up. Same thing, this happens, one not good mode while watching TV, you may be using device and that mindset. And next time also you're watching TV and taking that medication, gone the case, your medication is not gone properly, the technique is not right. Probably in the hospital and the pharmacist, a good pharmacist told you how to use it, that's not happening. So there are devices which are available to calibrate yourself, but who calibrate these days? How well these patients are educated, how much importance it is. There is inhale flow meter is available. With that, you know what is a quick deep breath is and how to use that DPI. So there is, but it's need a coordination. It's not that simple, I would say, but it's difficult. But this is something needs to be done. Only and best way is the pharmacist can do is when that comes for buying it again, and it happens in the Western world, but in India it doesn't. The pharmacist tell the patient that this is a device, it needs to be done comfort like this. One simple mistake people does is by chance they play when they're watching a movie and they play that open that cap of this DPA, that the drug is dispensed and stay in there, and you don't take it, you don't accentuate it, and that is stayed. And next time you take it, it doesn't deliver properly. These are so silly mistakes, and that's the reason that 80% of the people doesn't use inhalers properly. Then is your metadose inhalers. Then you have soft mist inhalers. So that is for those who are having difficulty. These mist inhalers is because they are applying with some pressure. So you just natural breath you need to take. I'll take this medication, but this technology is wonderful. The good and great pharmacists, pharmacists with pharmaceutics background, biopharmaceutics background, come up with these excellent devices, but they have been poorly used by the poor patients. And unfortunately, it doesn't work. And the nebulizers, this is a very economical one, but very complications is big in size. So somebody has to do his marketing job and taking this much nebulizer every time. So you may do 2 times, 3 times, and 4 times. One time he doesn't take it, then forget. He will not take it again. And the additional problem with this nebulizer is these tubes and all. This is the biggest problem that we see in COVID now. That medical equipment, the PPEs that we use has to be sterile and has to be maintained. And they need to change the tubes again and again. This much care one needs to do, and these things as normal don't happen, and it is some additional complications. One side it is cheap, but another side it is more complicated, leads to more problems. So this is where I would say pharmacist has a very, 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 very important role. So how a pharmacist can help? You can help in selecting the right inhaler. You can help in assembling that inhaler, dispensing the medication, and how to use it. So whenever the patient is coming and buying it again and again and checking it, and all the doctors in the Western world, even the Western system they do admit that they don't have enough time to see that patient, whether the patient is rightly using the inhaler or not. And they do advise and request the pharmacist take the help. And you see in the Western world, community pharmacists are available. You see that medical shops, even in India, we have so many medical shops, people are coming and going and buying. So you can make a nice rapport, or the community pharmacy make a rapport with the patient and tell them Are you using a medication properly? This is how you use it. Just an extra element of human touch will make you a very good pharmacist, and you are helping the patient and using the medication well, and it leads to overall a healthy nation. So with this, if nothing works, then is this bronchoplasty is another technology where you apply bronchoscope and send this laser technology inside and heat energy and reduce that smoke muzzle mass, and it works well, and it's outpatient. Just anesthetize and do that one time and ask him to go back home evening. Again, you'll come back after a week, this 3 times, and it's an effective strategy. But remember, it is a complement, but it's not a replacement therapy. And this is something needs to be done when nothing pharmacology is working, and it's an approved therapy by FDA. So this is all what we discussed, is various ways and means of addressing the disease. So we covered 3 elements: that's physiology and pathology. That's the first 3 parts. The villain part of characterization. Second part, we discussed about the precision medicine, the pharmacology, the existing therapies, where we discussed the kinetics, how to deliver, why deliver, and which one, which route, which dose, how to take, how much to take, and how to personalize that medication. And so we are talking about the newer therapies. So this is the tezepelumab, this is anti-TSLP. As you can see this image, and this is one of the alarming which we talked about earlier, which is also doing the same path. So it's also like working similar way in high eosinophilia subjects. And the phase 2 data, this is, and it is working very well. So now other option is this is the philipretant, and this is the oral agent. So some who doesn't like to take these injections, those who don't like to this subcutaneous injections, this is very easy option. And those are also 28 days. Many forget after 28 days. And again, pharmacist can play a role. So you're given so-and-so date. Is the time for you to take the medication again? This all happens in the Western world. And but it is easy. It's very difficult to remember the date, 28 days, and then take the medication. Oral is easy. Every day before breakfast or after breakfast. Sometimes you tell every day you take it and take on a routine basis. And these are very effective therapies. And mast cells are the which majorly release prostaglandin. It activates the main immune cells and affects so many processes. This is very effective and is also working well. But again, this is also going to work only in those having high eosinophilia. But what we want the medication is those who are severe, those who are not responding, are those which are not responding to corticosteroids, or which are ones who need to discover new medications, which is the need of the hour. And there are many patients not responding even to the best that we discussed today. So this tells the importance of generating pharmacists who can do the discovery and do much more research and bring back the health to normal. So this is the data where it is also working. So with this, I'd like to come to the last slide. So we are going to summarize. If you want to achieve optimal outcomes, you see that optimal outcomes is only possible when there is a good interaction of the physician, patient, and the pharmacist. And it's only possible when you come up with the understanding that endotype or phenotype and giving a highly precise medication. And it's again only possible if the patient adheres to the medication and if the patient uses the medication device properly. And all this is only possible by patient education. And this patient education can be done practically by the pharmacist. I think this is one good way of talking this topic on today's being a teacher's day, that education is so important. So if you see that education is so much important, just see in the world, who is the happiest country in the world. I think many of you can know the right answer for that. Happiest country in the world as per the surveys. It's Finland. Why it is happiest in the world, if you just think about it, then you get that answer. Why they are happiest? So when people are happy, when they are healthy also. When people will be happy and healthy, when there is proper education. And Finland education is the worldwide recognized best way of education. And why education is best there is because the teachers are respected and valued the most in that country. They're valued the most in the country. They're paid the highest in the country. And they have been valued, and the treatment, how a teacher handles a student is personalized. the medication strategies that we are talking, 9 P's that we are talking, all these 9 P's, a kind of 9 P's has been applied there by the teacher with the student. So that the exams are not the way we are putting in classifying students are distinction, first class or second class and fail, but there's no that system standard pattern of testing and passing the students. So if you want to be the healthiest country, and if you want to be the happiest country, I think these politicians and that managers or the controlling authorities should be properly educated, saying that a teacher is the one who makes the country happiest, who makes the best of the best professionals. Teacher, without teacher, a country cannot progress, and the health will not be the best. So that without proper teaching, the patient cannot come back to the normal, and country cannot be in the best of the best shapes. So this tells this importance of a good teacher. I hope all the teachers, I know that everyone do their level best, and the students also should be in a position to receive the best of the best that teachers are offering in their capacity. So with this, I'd like to conclude. The optimal outcomes can only be achieved with the holistic approach of considering 9 P's of severe asthma. I think I convinced enough. I'm not sure if anyone is not convinced. I'll be happy to answer if I'm not convinced and raise the question, and I'll try to address that. So in addition to these 9 P's, I would say that being a teacher, one needs is 3 years of professional attitude. You need to behave like a professional. You no more, once you go into the job, you're no more a student. You're not expected to do certain activities. As a student, it is okay. That's the time only you can do. You can enjoy, you can do mistakes. And we are as teachers, we need to correct and we need to tell this is right, this is wrong, but not when you are working with the patient or when you are trying to do something. So you need to show professional attitude, and you should gain professional aptitude, that is the necessary skills, and you should be adaptable to the situation. Situations keep on changing. Now we have COVID. This is a very new situation. We need to adapt, and the professionals have to adapt. The teachers should adapt. We're all adapting. The students need to adapt. Come back to the online education, and that's the reason we are able to have this webinar. Otherwise, it might not happen. So this is the adaptability we need to have, and more importantly, another 3 P's we can only do or achieve excellency if we have these additional 3 P's. Apart from those 9 P's which we talk, which are the professional knowledge that you need, but some attitude and aptitude is required to talk. And additionally, the passion to treat the patient, patience in dealing with the situation, because patients don't respond. All patients don't respond. The existing therapies which I taught, we see in the literature also that this severe asthma is one. Even after doing triple therapy, even after being IL for IL-13, you don't respond. There are some patients which don't respond, and you need to be empathetic about this difficulty that patient is in, and try to be perseverant in guiding that particular patient with the professional knowledge that you gain by going to the websites. So with this, I think as planned by the organizers, I maintained my time exact to the minute and completed by 11:15. This is the time that we have been discussed. I complete my topic. I thank all of you for being, and once again, happy teachers to everyone, and happy teachers to all my teachers who had made me. And if there is any mistake in this presentation, any lack or ignorance, this is all my fault. My teachers have given me the best, and I am trying to do my best. So with this, you see this 9 P's which we discussed, and we are completing, saying that once again, happy Teachers Day. Thank you for everything. To the Nagaraju and the Mybo and Dr. Chakravarthi and the entire team of the college for giving me this opportunity. And thank you all the participants for patiently listening till now. Thank you. So this my presentation is complete. Thank you. So I like to take questions.
Hi, sir. Myself, Kumar V.S, Assistant Professor, KL College of Pharmacy. Very happy Teachers Day, sir.
Thank you. Thank you. Yeah.
Sir, when I seen the title, that is 9 P's, so I eagerly waiting for your session, sir. What are the 9 Ps? But you explained the 9 Ps are very informative, sir. We are using those 9 Ps in daily life, like pharmacist, physician, personalized medicine, pharmacokinetics, dynamics, sir, like that. And you are giving very informative session today, sir. Thank you very much, sir.
Yeah, thank you. It's my pleasure doing this. Yeah.
Yes, sir. I knew very well, sir. At the time of paper, I attended your one presentation, sir. That is how to write a project proposal. At that time, I listened to your class, sir. But now again, I got a fortune to listen to your class again. That also on this auspicious day, it is very lucky for me to listen. Not only for me, sir, to everyone to listen to your class, sir. Thank you very much. So at this time, I'm remembering one quote, sir. Best teachers teaches from the heart, not from the book. So you are the perfect example for that quote, sir.
Yeah, thank you.
Yes, sir. So now this platform is open for the question and answers. Now, students, you can post the questions in the chat box. So the first question, sir.
Yeah.
Sir, you can see on your screen.
Yeah. So the question is, elaborate the instrument used in asthma animals, especially flow cytometry. So as you see in this animal studies, we are trying to do is that take that bronchial lavage and try to see what that mechanism that's taking place. So the various T cells are there, whether the cells that you see have any Th17 characteristics, are they to have Th2 characteristics. So these are basing on the markers. So each cell type carries their specific epitope on the surface, and this can be done with the labeling. And with this instrument, once you inject this after adding this antibodies and put in this flow cytometry, and this instrument is able to quantify those identify and as well as quantify the specific subtypes, and you know that how your mechanism or disease is doing or your drug is affecting those cell members. This is flow cytometry is, and it's a very common technique in all immunology studies.
Sir, another one, sir.
Yeah. So asthma and COPD have common symptoms including chest tightness, coughing, shortness of breath. How asthma awareness is important in this. So here, this is a very tricky question. So you need to differentiate whether the subject is having the same symptoms, because the subject is asthmatic. I think the question that Shivani is asking is how to differentiate the subject is having asthma or COVID-19. And so the best thing is COVID-19 is or not, it's infectious, is very known, and now the device, the techniques are there, and it's very detrimental, and it is contagious. So the immediate thing one should do is go for the testing COVID. So if it's COVID negative, very sure, then you are sure that it should be something else. Then something else could be tuberculosis, very common, and our immune systems get compromised in India. We get these issues, very similar symptoms you see it, and you remove that possibility by testing. Or you go by the spirometry, which you can know by that. Spirometry is also a very easy technique, and it doesn't need any blood sampling. You can just go to a good pharmacist, a good hospital setting, and just do the spirometry whether the lung function is compromised or not. So that's how you can differentiate and treat and take necessary precautions.
Nagaraju, you can ask the question.
Asthmatic drug for the COVID, sir.
Please, once again repeat, Nagaraju.
Yes.
Once again repeat.
Is there any chance for the repurposing of anti-asthmatic drug for the COVID, sir? Not for symptomatic relief.
Yeah. So there are many like glucocorticoids are the best ones, and because the issue is both common, and there's a large clinical trial by Internet's name in UK, and the trial found to show that dexamethasone is the best treatment, and there are many glucocorticoids like prednisolone, and there are many studies prednisolone, and dexamethasone. Yes, these drugs these are, let's not say, I would say these are not drugs specific for asthma. They are specific for doing immune suppression, and they have wide utilities, and definitely they have utility in COVID-19 also. And these are very cheap medications, and the one are very strong, very powerful. But situations like COVID-19, these are very ideal because the treatment doesn't very long. The virus doesn't stay for long, and very good way of treating it. And because it's intermittent and short period, and if it has to be long period, I won't suggest use steroids for any disorder.
Sir, thank you for your answer, sir. So now, so after closing these remarks, I am inviting Mr. A. Narayana Rao, sir, for the vote of thanks. Narayana Rao, sir.
Myself, A. Narayana Rao, Assistant Professor, KL College of Pharmacy, and Organizing Secretary for today's webinar, take the opportunity to present a talk about our thanks. Special thanks to today's speaker, Dr. Kumar V.S, who accepted our request and spent his valuable time in delivering such a wonderful talk. I thank all the participants faculty over here for your valuable questions. I congratulate all the student participants and their interest in research activities and attending this webinar. I thank KL University Management and our principal sir for encouraging us to organize such a nice webinar and for extending all necessary supports. I thank Mybo Group and its team for their constant support in making the event possible. I thank all my colleagues, students for their support hand in making the webinar a grand success. Once again, thank you one and all for your time and participation.
Yeah, thank you very much, sir. Dear students, we provided the feedback link in the chat box. Please go through it. Sir Kumar, sir, thank you very much for your session. So I'm officially closing the session. Thank you.
Yeah, thank you all.